Hello, my name is Matt Strelo from Stanford University, and in this lecture we're going to talk about the evaluation and management of patients with burns. So let's get started with the case. And our case is a 10-year-old male who's brought in with a scald burn from a hot liquid. We utilize our emergency and medicine approach to this possibly critically ill patient by evaluating, thinking, and acting simultaneously, where in our evaluation we're focusing on the general appearance ABCs, thinking about whether this patient is kind of in our sick category or our not sick category, and then acting early and performing any immediate interventions to stabilize that patient. So our initial assessment of this patient, we see that he's uncomfortable from pain, but he's alert. His airway appears clear, and he's able to state his name clearly and say his name is Ajay. His breathing is rapid, but he's speaking full sentences and doesn't appear distressed. And on circulation, he has a rapid, strong radial pulse. Our last step in our initial assessment is to get a full set of vital signs. And this patient's vital signs are a heart rate of 140, a respiratory rate of 24, a blood pressure of 90/50, a normal oxygen saturation and temperature. So remember that we want to use age-appropriate vital signs in this patient. So 90/50 is a normal blood pressure in a 10-year-old. The heart rate is a little bit fast. The breathing or respiratory rate might be mildly elevated, all consistent with this patient being in pain, but also you should be worried about shock. So as we think about this patient in our initial assessment, we're asking ourselves, is this patient sick or not sick? And the answer here is yes, this patient is most definitely a high risk for being sick or critically ill. So we want to act early in these patients or intervene. So the first thing we're going to do is we're going to position this patient. But what other early interventions do we need to focus on in a burn patient? And some key things to focus on are assessment and evaluation of the airway and stabilization if necessary, and control of the environment. You have to be careful in burns early on for them developing airway obstruction. Airway obstruction and respiratory distress are frequent in these patients and probably the most common cause of early death in the burn patient. So you want to evaluate thoroughly and intervene early. So what are we going to look for when we're evaluating a patient's airway? First of all, you're going to look for burns or soot in the region of the mouth or nose. Look inside the mouth and in the nose to look for any signs of burns or pharyngeal swelling. Listen to their voice. See if it's hoarse. Ask them, does their voice sound normal to them? Listen for inspiratory stridor. And I always like to ask patients, do you feel dyspneic or short of breath? If they do, that's generally a very concerning sign that that patient's at a high risk for airway obstruction. As I evaluate these patients, I try to categorize them into one of the following categories. Those that require immediate airway protection, those with a deteriorating airway, those that appear to have a temporarily stable airway but do have some concerning signs or symptoms, and those with a stable airway and no high-risk features on my initial exam. So those requiring immediate airway protection are those that are having cardiac or respiratory arrest, or those who are obviously having a rapid progression of airway swelling and obstruction. In these patients, you must immediately intervene and plan for a difficult airway. So you don't want to try to place an LMA or any other upper airway device. You want to get full control of that airway by doing endotracheal intubation. However, given the swelling and the difficulty in these patients, you need to be ready to perform a surgical airway or a cricothyrotomy if you fail to get that airway. The next group of patients is those with a deteriorating airway. They have some signs of respiratory distress that are significant, such as shortness of breath or stridor, but they're not in recurrent respiratory or cardiac arrest. So in these patients, if we have time and we have the resources, we want to call for assistance, meaning try to get our most senior or experienced person in airway management in the hospital to that patient's bedside to assist in managing this patient's airway. This is not a case where you're going to be able to wait for someone to finish a case in the operating room or come from home. So you're still going to have to manage this patient's airway fairly early and rapidly before that swelling gets worse, which it typically will. In these patients, you should also be ready to intervene with a surgical airway, even if you have your most experienced person involved. The next group of patients is those with a stable airway, but do have some concerning signs or symptoms. So these are patients who have maybe very mild respiratory distress or very mild stridor, or they have secondary signs of an airway injury, such as burns around the face or mouth, or maybe some sputum in the black sputum when they cough or spitting. In these patients, we can start some cool mist, put them on high flow oxygen, observe them closely, but you should be ready to intervene because a fair amount of these patients will require endotracheal intubation and airway management, and you definitely don't want to wait until the swelling has got dramatically worse and managing that patient's airway is much more difficult. So if you see a patient like this and they seem to be going the wrong direction or deteriorating, intervene early. I also like to evaluate these patients a little more thoroughly. So this was a patient that was in a fire. She had a little bit of a hoarse voice and some singed nasal hairs, but otherwise looked pretty good. And so we took a look more posteriorly and inferiorly down that patient's upper airway to evaluate the epiglottis and the area around the vocal cords for swelling. Our final group of patients is those that appear to have a stable airway and don't have concerning signs and symptoms. I still place these patients on high flow oxygen, which we may discuss a little bit later, and I observe them closely, but we're not planning on immediate intervention in this group of patients. The other thing we want to do is establish an IV in the vast majority of these patients because we want to administer pain control. Burns are frequently very painful, and early pain control and aggressive pain control are an important part of management. Be careful though, because you don't want to place an IV through a burned part of the skin if possible. At times, if the patient has very extensive burns, this is unavoidable, but always try to place an IV through intact, non-burned skin. Additionally, you want to control the environment very closely. The skin helps a lot in thermoregulation, or controlling the body temperature. So patients with significant burns are at a high risk for hypothermia. We also want to remove these patients' clothing, so we're frequently exposing them to the environment. So after we have got that burning process stopped, and we then want to cover them with clean sheets, and providers should be using gowns and gloves to limit any exposure to potential future infections or bacteria in these patients that are going to be at a high risk for infectious complications later. So our immediate interventions in our burn patients typically revolve around positioning the patient, administering high flow oxygen, placing an IV in a non-burned area, and controlling the environment and setting up a clean environment for that patient. In our particular patient, we had a young 10-year-old with a pretty significant scald burn who had a rapid pulse and respiratory rate. His airway was okay though, and he had no evidence of any airway injury. So oxygen is probably an option in our actions, but not necessary. But we do want to place that IV, give pain control, and get the patient in a clean setting. So in summary, when we're evaluating early our burn patient, we want to focus on the airway because a lot of early deaths occur from airway obstruction and a burn to the airway. And we want to manage or intervene with endotracheal intubation or a surgical airway early in these patients with dramatic or significant signs or symptoms. We want to administer oxygen to most patients, and especially all patients that were exposed to fire. Control pain aggressively, and this typically means with IV narcotic pain medicines. And to avoid hypothermia and keep a clean environment. Thank you.